Welcome to The Explainer. Today, we're digging into a really critical but often missed phenomenon in patient care. We're going to explore this based on two key publications: a 2025 meta-analysis from the journal Pharmaceutics called Prevalence and Risk Factors of Augmented Renal Clearance, and a 2025 narrative review from the Journal of Antimicrobial Chemotherapy titled The Long Walk to a Short Half-Life: The Discovery of Augmented Renal Clearance. And of course, the links to the bibliography are right there in the description below. So let's start with a clinical puzzle, one you've probably faced in the ICU. You've got a critically ill patient, you're treating their infection, their serum creatinine looks great, perfectly normal, but for some reason, they're just not getting better. The antibiotic therapy is failing and you're left scratching your head. Well, what if the problem isn't the bug and it isn't the drug? What if your patient's kidneys are actually working too well? So well, in fact, that they're clearing out that life-saving medication before it even has a chance to work. That's the core idea we're going to unpack. So let's put a name to this condition that's at the heart of this whole clinical mystery. It's called Augmented Renal Clearance, or ARC for short. And it's basically a state of enhanced kidney function where drug elimination just goes into hyperdrive. We typically define it as a creatinine clearance over 130 milliliters per minute. For years, we've been laser-focused on kidney failure in the ICU. ARC completely flips that script. The challenge here isn't failing kidneys, it's kidneys in overdrive. Now, what's really fascinating is how this was all uncovered. You might think it was in some high-tech lab, but nope. It came from solving a very practical, logistical problem. The story starts back in the 1990s at Baraganath Hospital in South Africa. This place was huge, and getting a lab sample from the ICU to the main lab was a full-on expedition. We're talking a kilometer walk. So to make life easier, the ICU team just brought a chemistry analyzer right into their unit. Suddenly, with testing right at their fingertips, they started measuring creatinine clearance routinely. And they started seeing these numbers that just seemed impossible. Clearances of 200 milliliters per minute. I mean, that flew in the face of all the medical literature at the time. Their first thought was that the machine must be broke. But then, the data confirmed it. Later studies showed this perfect straight-line relationship. As the measured creatinine clearance went up, so did the clearance of cephalosporin antibiotics. It was undeniable. Those impossible numbers were real, and they had a direct, powerful effect on drug levels. So that's how we found out about it. Now let's talk about just how common this supposedly impossible finding really is. The numbers are, well, they're pretty eye-opening. A huge 2025 meta-analysis, which looked at 70 different studies, found that the pooled prevalence of ARC in critically ill patients was a staggering 39%. That's not some rare condition. That's almost 2 out of every 5 patients in your ICU. But the risk isn't the same for everyone. The numbers get really dramatic when you look at specific populations. In the neuro ICU, it's 74%. I mean, 3/4 of your patients. In the trauma ICU, it's 58%. These are definitely our highest risk groups. And the data really paints a clear picture of who is most susceptible. The younger the patient, the higher the odds. Being male more than doubles the risk, and a trauma diagnosis, that makes it 2.5 times more likely. So your classic patient at risk for ARC is a young, male trauma patient. So why does this all matter so much? Because ARC effectively pushes our patients into a sub-therapeutic danger zone, where our standard go-to drug doses just aren't enough. Here's a great way to picture it. Think of a bathtub with the drain wide open. You can turn the faucet on full blast, pouring water in, but the level never gets high enough because it's all just rushing out the bottom. That's exactly what's happening with renally cleared drugs in a patient with ARC. So what's driving this? Well, it's a direct result of the body's massive inflammatory response, or SIRS, to things like trauma or severe infection. The body goes into this hyperdynamic state. Cardiac output shoots up, and blood flow to the kidneys gets cranked way up. This huge surge in renal blood flow is what kicks the kidneys into overdrive. And look, this isn't just some interesting number on a lab report. The consequences are severe. We're talking about antibiotic failure, poor seizure control, and what's really scary is that it promotes antibiotic resistance by exposing bugs to these low sublethal drug levels. Okay, so that brings us to the most important part. What do we actually do about this at the bedside? Let's talk about an action plan. I want you to walk away with 3 key practical steps. First, suspect it. You have to have a high index of suspicion, especially in those young trauma and neurocritical care patients. Second, measure it. And I mean really measure it with a timed urine collection. Do not trust bedside equations like Cockcroft-Gault. They will let you down here. They just can't see this. And third, adjust and monitor. This means you may need to use higher doses or more frequent dosing, and if you have therapeutic drug monitoring available, use it. So, to wrap it all up, augmented renal clearance is not a rare thing. It's a common, high-risk phenomenon that's hiding in plain sight, right behind a normal-looking creatinine, and it's causing our treatments to fail in our most vulnerable patients. If you remember one single thing from our time today, let it be this: normal serum creatinine does not equal normal renal clearance. Say it on rounds. Tell it to your colleagues. It's the mental cue that reminds you to look deeper. And that brings me to your call to action. The very next time you're faced with that patient, the one with normal labs who isn't responding to treatment, I want you to stop. And before you change the drug or hunt for a new bug, I want you to ask yourself, could the kidneys be working too well? Reconsider the clearance. That might just be the key that solves the entire puzzle. Disclaimer and bibliography in the description.